बीच में लाऊंगा।
जी।
और एक डॉक्टर हर्ष को आपको बुलाना रहेगा, मतलब 8:15 को मैंने उनको बुलाने के लिए। तो आप उनको बुला के रखना बीच में, मीटिंग
ठीक है।
ज्वाइन करा देना। उन लोगों से मैं 2-2 मिनट बीच में बात करूंगा।
ओके।
ठीक है।
या।
बोलो कब जा रहे हैं अपन लाइव?
वी आर लाइव नाउ सर।
ओके। सो हेलो स्टूडेंट्स, हेलो माय डियर। A very congratulations to all of you. Many of you would have gotten ranks and must be planning your entrance preparation for your residency. And you must be thinking, should I be taking surgery or not? And some of you would have gotten surgery in your first round since the results just came out. So you must be thinking, should I take or not? Is it the right choice? So this is for you guys. If you are in that boat where you're not very sure, should I opt for it? Or you've already taken and you just want a little bit of confirmation about what is lined up for you because there are other rounds pending where you can change. So this is for you. So I am Dr. Amrit Nasta, your faculty from Conceptual Surgery, where I'll be giving you a little insight about the kind of things that must be going on in your mind, some questions you must be having, as well as some misconceptions. You must be thinking that surgery means very hectic, no work-life balance, and maybe lot of money, maybe no money. Is it saturated? So all those things I will be addressing. You can of course ask your questions on the YouTube, and I will try to address them as many as possible. Right. So let's get started. And I have invited a few people, some students who are in the residency process, who will share their insights, as well as some practicing surgeons, because you need a correct perspective. You will be like, as a fresh, neat aspirant who has just gotten a rank, your perception of branches like surgery, orthopedics must not be the as it is in reality. It may be a little different. You must have seen as an intern, what goes on, how surgeon's life is, how the JR1, JR2 are, surviving. So that must be little like a put off. So I will try to give you the correct insight. Okay. And you can choose to believe it or not. That's entirely up to you, but I will try to give you as much as real world scenarios. Okay. But before that, let us give you a little idea about how my journey was. Like, how did I become a surgeon, or rather, why did I become a surgeon? Should I have even taken surgery in the first place? What do I feel about it now? So, my MBBS, so I am based in Mumbai, and my MBBS was from a government institute, that is Grand Medical College and JJ Hospitals. I had a very nice 5 years of MBBS internship. It was quite comfortable, and there was a decent exposure. And in my time, there were not so many distractions. Social media and all was not there. So yeah, we actually got a good hospital environment. We could actually see patients. Today, things may be a little different. And then I did my internship and I prepared and I got my rank in the first go. So I was not really a nerdy student, honestly. I was never in the top 5, top 10 of my college. I was always somewhere in between. But I got a good rank in my first attempt. And at this 282 NEET rank, it was not called NEET back then. It was called All India PG. The name was different. So my AIPG rank back then in 2011 was 282. So at 282, the value is same as today. I would have gotten everything, and not just surgery or ortho. Options were open for radio, medicine. Even in my time, radiology was number one. Okay, now internal medicine is becoming number one choice. In my time, it was radiology, derma, ortho. They were the top three. So everything was open for me, but I opted surgery intentionally. Various reasons, I kind of developed a liking for it in my MBBS days, and I was one who wanted action, like I wanted to do something, not just consult and prescribe. Little bit more intervention, little bit more in your hands, not so much to imagine. It should be like in your face. Like if you see a hernia, you know it's a hernia. There is no imagination. So I wanted to be in the heart of action, which is why I opted for surgery. And let me tell you, at 282 rank, I would have gotten surgery also anywhere and everywhere. But the institute where I got, that was KEM Hospital, I was the last entrant. So there were 6 seats at that time in open category, and I was the sixth person, which means up to 282 ranks, 5 people are already taken surgery in KEM itself. So I was the last person, lucky. Jabki in today, nobody's opting for surgery. In today's day and age, at 282, you will be the first one to enter these kind of institutes. So I entered KEM Hospital. So this was 2011, 2014. and it is one of the premier institutes, no doubt, in Mumbai, where the exposure and everything is enormous. It's a government institute, very busy hospital. So how my residency was, we were not so many residents in my batch. We were 10 residents, and the work had to be divided. So there were 8 units, and you would have weekly emergency duties, and emergencies were crazy. Work hours were obviously crazy all 3 years. It was not just JR1, JR2, JR3 also had to work. So on most days you were working like 18 hours, 19 hours. Emergency, so you are working 36 hours. Means you start on a Monday morning. If that's your emergency day, you will finish on Tuesday evening. So work hours were enormous. Currently, the number of residents in most government institutes, at least in Mumbai, Maharashtra, are much more. They are almost 2.5 times. Like in KM now, there are 20 plus residents in a batch. So automatically work has reduced a bit. So work hours at that time were easily 18 hours a day, easily, plus weekly emergencies. You had a great exposure in terms of the quality of work that the consultants were doing. So, exposure to laparoscopy at that time was not very common. Now everybody is doing laparoscopy, but I'm saying 15 years ago, laparoscopy was quite new. Still, there was a lot of lab work happening. We wouldn't get to do anything. JR3 maybe would get to hold the camera at that time. But you had exposure. Now there is robot in a lot of government hospitals, private hospitals. So exposure has definitely become better. Second thing is cutting. Now you always think that, okay, if I'm taking surgery, I want cutting, cutting, cutting. But honestly, even in a government institute, the cutting is more in emergencies. Like you'll get a lot of cutting, that is debridements, amputations, gangrene, open appendectomies, maybe due perforations, laparotomies. That is the kind of cutting you get in emergency. Elective cutting in government institutes is not that much, maybe in the first couple of years. Yes, you'll get to do a lot of open hernias, hydrocele, but that's about it. More than that, laparoscopic work, very few institutes are going to offer to you as hands-on. So what will happen in most places is when you will finish your 3 years, whether you did MS or whether you did DNB, you will have a basic level. Maybe some of your peers would have done some things more, some things less. Like in some places, you'll get good laparoscopic exposure. In some places, you'll get good clinical exposure. Some places you'll get a lot of cutting. But at the end of the 3 years, you will have a basic understanding, basic knowledge, and to do more than that, like if you want to go into private practice immediately after general surgery, you won't jump into private practice. Even as a general surgeon, you would want to do 1 or 2 or 3 years in a government place where you get some exposure, where you are a little independent as a SR or a lecturer. And after that, you will go into private practice. Otherwise, after residency, after MS or DNB, you will go for super specialty or fellowships. So that's where it goes. Our mentality is 3 years of residency will make me a surgeon. That is not true. You are not going to be a surgeon. You will be a qualified surgeon, but you won't be a practicing surgeon. Okay. So this is what my residency was. And in today's day and age, most government institutes will be similar, maybe a little bit up and down. Private institutes will be different. There, the clinical exposure, the time that you give to a patient will be more, but the hands-on will be relatively less, but there'll be a basic cutting, which is why I have with us today Dr. Sanjana. Sanjana, if you can unmute and show us your face. She is doing her residency.
Hi, sir. Can you see me?
Yes, so Sanjana, I'll just take
Yeah.
1 or 2 minutes of your time. I know Sanjana from her days. She's a MBBS pass out from Sion Hospital in Mumbai, one of the prestigious colleges, and now she's doing a surgery residency in Chennai. So Sanjana, tell me a little bit about your institute and what year you are in and what kind of work have you been doing? Because when I tell people that DNB surgery is not a bad choice, they refuse to believe. So let us hear from the horse's mouth. Yes, Sanjana, tell us where you are.
So, I am right now in my third year at Sundaram Medical Foundation in Chennai,
Hmm.
and I got a rank of around 17K in my year. And at that time, I was totally okay with the idea of DNB general surgery. I was getting MS in some private institutes in some interior parts of Maharashtra, but one, I did not want to spend that much money. And two, there were too many residents, like Sir said, for maybe too little patients in interior Maharashtra or whatever. So I chose this institute specifically even above many institutes in Mumbai because there are only two PGs per year. And I feel like that would keep me pretty occupied, and it is keeping me pretty occupied. So I feel like the institute that I'm at is actually a hidden gem, and I'm very happy with my institute. I don't know, I may not know, I can't evaluate with my peers if my hands-on is worth it, or like, again, I won't feel like a full-fledged surgeon at the end of 3 years, but I'm very happy with the soft skills that I have developed, like counseling patients and speaking to sisters and everyone else in a good way, and like counseling them with respect to all the complications and like the need for like post-operative care and the cost of procedures and all of that, which I'm very happy about learning.
So
Yeah,
Sanjana,
sorry.
just allow me to interrupt you a little
Mhm.
bit. You are now in your entering third year, means your 2 years are complete.
Yeah,
So just
yeah,
tell
I've
me,
just entered
over the
third year.
2 years, roughly, what kind of work would you have seen, exposure, like the kind of cases, and what kind of cases do they let you do? Like, how much do they let you participate?
So, in our hospital, there we don't have seats for super specialty. So we see super specialty patients also. So we
Okay.
get a good inflow of general surgery, a very good inflow of urology,
Uh,
neurosurgery, vascular surgery, cardiac not so much. Thoracic we have basic VATs and stuff like that. Pediatric you have the bread and butter cases, and plastic surgery we have a good load. So again, from first year, they like we go more towards plastic. So you learn how to use the instruments, suture well, and stuff like that. Amputations, debridements. By the time you're ending your first year, you will start scrubbing for hernias. You can start doing skin to skin by third year, depending on the consultant and how easy the case is or how difficult it is to dissect the sac. Now in the end of second year, you can get lab hands-on as well. And
you're getting lab hands-on at the end of second year,
yeah,
and your
yeah,
institute is a DNB institute.
yeah. I was struggling because I'm left-handed, so they would take over at some point of time, but they did allow me to, and it's very kind over here. I did struggle a lot with open surgery also. I struggled a lot with lap also, but they have been very patient with me,
Uh,
and despite me being left-handed and allowed me to practice, and we even have like a tie-up with another hospital where they send us for a laparoscopic workshop for 3 days, and that has helped a lot. And after that workshop, I've been able to assist a lot better in lab.
That's wonderful to hear. It's so reassuring. We are so fixated on certain institutes with certain names. As you are saying, there are so many hidden gems where you are getting exposure to super specialty, laparoscopy, like the whatnot. Whereas normally people, even if they get just general surgical exposure, they are more than happy. So I'm very happy to hear. Sanjana, just one question and then I'll let you go because you are just two residents, so you have a lot of work to do. Just one question. What is your day like? Do you get to sleep? Since you must be having alternate day emergencies, do you even get to sleep?
So that was in first year. Now that I'm in third year, the number of on calls has definitely reduced.
Okay.
So actually, I guess you do. You get used to the lifestyle. It's only a matter of 1 year. In our case, maybe 20 months. But
Okay.
it's okay. In the morning, depending on the case timings, I'll come for rounds at around 8 a.m. If there's no early morning case, I
Hmm.
can come by 8 a.m. We'll pre-round before all the consultants come,
Okay.
and then one by one consultants will come for rounds. In the like while this is happening, OTs will also be happening parallelly, and
Okay.
it's not like a government hospital where all residents go to see one case. You are
Okay.
assigned a particular case.
Hmm.
If there is no work in the ward and there are no cases in the emergency that you have to handle at that time, you can go see the case that you are not allotted for.
Okay.
And so basically parallelly you will be handling ward, OT, and ER. And
Okay.
then after your elective OTs are over, you will have evening rounds,
Yeah.
remaining ward work,
Yeah.
dressings, and stuff like that. And then you will basically come home on good days by like 8 p.m. On bad days, it can go even beyond that. But
I wouldn't
again,
call that
because
as a bad day. Yeah. I mean, bad day is like
yeah,
11 or 12. That's also okay. That's not really bad.
I don't think that's bad. And I feel like for like to see so many cases and have like decent hours and come home and at least sleep for maybe 5 hours, it's okay, it's all right.
That's amazing. So thank you so much, Sanjana. I will not trouble you too much. Just before you go, I would just like to let people know of some myths. MS versus DNB. She's doing DNB. She's quite happy. Can girls take up surgery? She's taken up surgery, and I don't think that's really an issue anymore, at least for general surgery. There are enough women who take up general surgery. So, and I'll tell you, Sanjana is very short and tiny. I've seen her personally.
Yeah.
So don't feel she's like, big body. She's very tiny, but she's doing a great job. And thank you so much, Sanjana. I'll allow you to leave here as we continue with
Okay.
this. Thank you for
Thank
your
you, sir.
time. So normally I would have, given you this government versus DNB MS thing, and I would have told you my points of view, but you heard something from the horse's mouth. The idea is you need to find the right institute. You find the right institute with good seniors, you'll be happy. Or if you have bad seniors, bad department, wherever you are, MS or DNB, it can become tough, right? So that was about my residency. Now, what do you do after residency? What are your choices? Most popular nowadays is super specialty like MCH. There are so many MCH options which also require entrances. So don't think NEET PG was the end of your entrance life. If you're thinking of super specialty, you'll have to give entrances. Alternatively, you can do fellowships, national fellowships, international fellowships. There are many options if you want to go to US or UK, a lot of European cities, a lot of Far East countries, Singapore, for different specialities are available. Whatever you do, if you're planning to go into private practice, you will require some work experience, right? You will not jump immediately after your MS or immediately after your MCH. If you have bond, you will do serve your bond. So some work experience is required. Now, why am I telling you all this? This is how my journey was. So my MBBS and MS, after that, I did not do MCH. Okay, and I'm practicing in a city. And normally in a city like Mumbai or Delhi, if you are practicing surgeon, you would require MCH for most of the specialties like oncosurgery, plastic surgery. You would have to become an MCH. But after my MS, I went into a branch which does not have MCH, at least not as of now. So I went for bariatric surgery. I did bariatric fellowships in India and I did bariatric fellowships in Belgium. So I got a good exposure and enjoyed the branch. So I was like, okay, there is no MCH for it, go into practice. But I didn't go into practice immediately. I worked under a surgeon for a long time where I enhanced my skills. So it's not that I finished my MS, finished my fellowship straight, do bariatric surgery. You need some work experience, which is what I feel. We put so much stress on where we are doing a residency from. It's not enough. It's never going to be enough. You will need work experience and then you will become a consultant. Now, what choices you have after or when you want to go into practice are usually these four. And a lot of people don't know this. These are the four ways where a surgeon will go into practice. This is different from a non-surgeon, from a non-surgical branch. You can work in a government institute. So there are a lot of government hospitals where you will get jobs, at least in Mumbai, for surgeons, there are enough jobs. So don't think surgical branches are saturated. Enough jobs, like where I was in KEM, as of today, there are available vacancies in the surgical branches. So those jobs normally are going to be fairly secure. You will have fixed hours. You will have a full team of residents underneath you. You will have interns under you. You will have maybe a senior consultant who will be guiding you. So you are in a very safe zone. You will get to do whatever you want. You will have a fixed work hour. Sundays will be off, and you will get summer holiday. You will get Diwali vacations. Until you retire, you can serve in a government institute. It's a very safe job. If you're not very ambitious, definitely you can do this. Second thing, which is more monetarily rewarding, is a private practice, which is what most people who enter surgery want to do, at least most people. So you can take a full-time job in a corporate hospital. These are tough to get. At least in Mumbai, if you want a full-time job, you would have to be a super specialty, means MCH. A plain MS, it's difficult, honestly. But if you get a job, again, there is no job security because they expect you to deliver the figures. Means you have to do so many cases in a month to generate so much revenue for them to keep you there. So you are kind of at their mercy. Very popular now is freelancing. Freelancing means you take attachments in different hospitals and you have to have your own OPD, your own patients. Okay, so it's on you to get the patients. you operate and you get a fee from the surgery. Okay, that is freelancing practice. You are the boss, but obviously you will put your heart and soul into it. Right. And there'll be periods where you'll have not so much work, like if it's a festival time or vacation time, work will be less, earning will be less. There'll be spells where work will be more, earning will be more, and it eventually balances out. So most people nowadays, myself included, are into freelancing practice. And for a surgeon, the best way to make money, but that option is not for everyone, is to have your own hospital or own setup. So if you are second or third generation doctor and your parents or grandparents have their own hospital or nursing home, this will be quite monetarily rewarding. But not everybody has that choice. So these are the options. Don't think surgery means heavy life, surgery means no work-life balance. You choose the life that you want. So don't just think of residency. Residency depends on your institute. What after residency? These are the choices that you need to think. Now, before I answer these questions, I would call my friend. He's a practicing surgeon in Mumbai, Dr. Harsh. Dr. Harsh, are you here? You'll have to unmute. You're still muted. So while he unmutes, I'll just tell you why have I called him here. He's a practicing surgeon. He's my peer. Means we are all in our late 30s. We have gone through the difficulties of surgical practice. We have set up our own practice. So you need to know, get a proper bird's eye view of where your life will be when you're late 30s, 40s, 7, 8 years into practice, how your life is going to be, because we only see residents, what the GR1, GR2 tell us, and then we are like, surgery, not for us. But see how life is going to be maybe 7, 8 years into practice. It's not what you think it is. Okay, so Harsh, are you here?
Yeah, I'm here. I'm unmuted. Sorry, the iPhone privacy settings didn't allow me to unmute myself.
So Harsh, I'll not take too much of your time. I'll just ask you a few questions about how life is as a surgeon and how do you feel about surgery being, he was my batchmate from 2011 onwards. So we have been into practice after residency for almost 10 years. He's actually more senior than me because his practice is very well established because, he has put his heart and soul into it and multifaceted person. So first, Harsh, are you happy you took surgery or do you regret it? And tell an honest answer.
So I'm happy I took surgery when I'm in the OR. I'm unhappy that I took surgery when I'm trying to generate patients and generate work. So, I mean, in the OR, everything works well. I'm very happy I'm operating. But to get to that situation, I need to be unhappy to
So
generate the patients.
you're speaking like a true surgeon, and students who listen, they don't see the side of a surgeon's life. They only see the hectic part. They don't see the joy that we get when we are actually operating. I'm not trying to sell the brunch, but I'm just telling you a correct perspective. A more realistic question: how long does it take to set up a decent practice if you are a freelancing surgeon or if you are going into private practice where you feel you are in a comfortable spot monetarily? Because first we think of money normally.
Right. So it took me around 2 to 3 years. But again, it was COVID times. But if you're a well-trained surgeon, I don't think it should take anything more than 12 months. If you are in an area where, surgeons are less, and if you're trained in fields that not many people are trained in,
Mm.
it is very easy to generate a practice. But if you're doing general surgery, for example, if you're doing perianal work, or if you're doing sebaceous cysts and lipomas and lap choles and lap appendectomies, those that dime a dozen general surgeons will be doing it on a day in day out basis. So you need to differentiate yourself in some way under the umbrella of general surgery to build up a practice quickly.
So do you feel surgery is saturated in the cities? Means
In the
that's why people are like, we don't want to take surgery. Like I'll tell you the results of the recent NEET counseling was most people opted for internal medicine, second
Hmm,
was radiology. And they are like surgery means saturation. Do you believe
right,
that? Since you're into practice, you are like facing
right,
surgeons left, right, center.
right. So I don't think surgery is saturated per se. There's enough work for everyone, but
Okay.
you need to be in the frame of mind to move to an area where you will get work.
Okay.
You cannot, for example, South Bombay is a saturated area where there are too many general surgeons and there's a limited pool of patients because many people move out of this area. But if you're willing to move to an area of your city or your town where there is a need or where there is a lack of expertise, those areas you're definitely going to do well. There's no two ways about it.
Okay. And just one last question. Now you are almost 10 years into practice and you are having a busy practice. Do you get time for yourself, for your family, for your son at the age of, let's say, late 30s? Or do you feel it's too busy, there is no time for self, and that work-life balance is not there?
So it depends on yourself. Now, I can say that when I started my practice in the first few years, because it was COVID times, practice wasn't very heavy. I did get a lot of time with my son, my wife, my family, everyone. Then, as practice got busier for the next few years, I think practice again, kind of picked up. I was trying to focus too much on practice, and that was a time when my work-life balance suffered. But I mean, there's a curve. Once you hit that peak, you realize that it's once you plateau rather after hitting the peak, you realize that work-life balance is important, and that's when you have to consciously make a decision or an effort to kind of weed out certain types of surgical patients or certain not accept certain types of patients or not go to certain types of hospitals, and eventually you will get enough time for family and for your kids.
So, as I see it, the more senior you become, the more you're able to generate time for yourself and balance in your life. It's not
Absolutely.
all that I'll be working 7 days a week, 12 hours a day, and I'll have no time for myself or for my family.
Absolutely.
That's exactly what I wanted you to say, because I tell this to students all the time, but they're like, you know nothing, you are just promoting your branch. That's why I called a practicing surgeon who is in the peak of his practice. And I'm sure as you become more and more senior, you will get more time. But students don't see this. So I'm so happy you're here. And I think I'll let
Absolutely.
you go. I'm sorry I disturbed you.
No
But
worries.
thank you so much, Dr. Harsh, for joining us. And students,
Thank
I hope you took a real world scenario of how practice is, right? So basically, you need to have an idea of what surgical practice really is. He is 39 years old and he says now he's able to make time. What I am trying to tell you is these are some of the issues that come in our life when we are choosing the branch and what goes for a surgical branch. The question students have is there going to be work-life balance? Work-life balance will take time. Once your practice reaches a certain limit, you will be able to get juniors under you to do the donkey work. And if there are people to do the donkey work, then you will be able to get some balance. Initial few years undoubtedly is going to be tough because you want to build your practice. This may not hold good for non-surgical branches. So we are more tempted for internal medicine thinking I just have to work in the clinic. Maybe 3 hours in the morning, 3 hours in the evening. It's not so. Initially, even they have to work. They have to go for camps in small towns, small villages to get patients. From where will you get the patients? That's the main problem. And getting the patients will take time. Okay. So work-life balance is tough in the initial few years. Will I get a good monetary reward for my work? Can I buy a Mercedes or Rolex? This holds good for most surgical branches and most heavy clinical branches. So if you are good, you will get enough reward. So surgical branches more. It's like we look at this, effort to reward. How much time to how much outcome. Monetarily, if you are in a good surgical branch, if you are able to do enough number of surgeries, the rewards will be proportionately good. You won't have to do OPD whole day versus doing one surgery. It will almost match up. So you think of it like that when patients come to me, I may see 5, 6 patients, but they should get, operated by me and not by someone else. Will I feel happy at the end of the day? Will this branch give me job satisfaction? The branch that you take, remember, it's your branch forever. Money may make you happy, but you will need some job satisfaction, which is what we get from clinical branches, more so from surgical branches. Like you heard him say, when I'm in the OT, I'm very happy. When I'm doing my thing, I am very happy. It's the same story for all surgeons. They are happy when they are in the OT. It gives them that thrill. And no two patients are the same. So every patient can pose a new challenge. So when I do bariatric surgeries, even though I've been doing only bariatric surgeries for almost 8 to 9 years, in some or the other patient, some new problem will pop up. And it will require some thinking, some intervention, some new planning, some new step to solve the problem. And the main thing, am I the hero of the story? See, we all need some gratification, some, assurance that you are doing a good job. Surgical branches will give you that. Patients, relatives, if things go well, you will see the result right in front of your eyes. If I simple, you operate a hernia, the hernia is gone, the patient is asymptomatic, he's happy. You can see it on the post-op day one. Cholecystectomy, cholecystitis, he was coming with pain, appendicitis, you did the surgery, next day he is pain-free. The outcome is immediate. There is no imagination. It's all in your face. That's what originally tempted me towards surgical branches. Of course, there are difficulties. It's not all, it's not Christmas for everyone. Do people trust only surgeons with white hair, senior surgeons, or surgeons with no hair? In a way, yes, but this is kind of changing now because now if they trust surgeons who are more on social media. Now the things have gone from seniority to social media seniority. So you will have to build a little bit of PR. Your public relations have to be good. That's how you will get the patients. Initially, life will be hectic. Initially, you will attend to emergencies if you are in a surgical branch most of the times. See, in bariatric surgery, emergencies are very few. Once in a while, I may have to go at night, maybe once a month. But in the residency phase, the early practice phase, emergencies, working on Sundays will be there initially, like maybe 4 or 5 years at least. In most big surgical branches, you will require a team. Like the people I work with, the associate surgeon, anesthetist, you have to build a team. This is the biggest drawback. You don't need this in a medical branch. You are individual, your own. All you need are patients, but here it's not just patients. You need people to work with. You need a co-surgeon or maybe two co-surgeons. In bariatric surgery, I need a nutritionist or a psychologist. You need hospitals to operate. You just can't open your clinic and work. These are some things, but over time you find your way. And the actual earning, the true money that you make, is not what the patient feels. If the patient goes to the hospital and gets operated by you, and the patient has paid 1 lakh rupees for the surgery, surgeon does not get 1 lakh rupees. Don't be under the impression that all money goes in your pocket. It is rewarding, but it is not absolute. You will get a part, a percentage, which will be anything between 20% to 40%, depending on your seniority. So actual earning is not what the patient is paying. You are getting some fees, so that will hurt you, that I took all the risk, I got the patient, but you are using a hospital service. You are hiring associates, people to help you. All of them have to be paid. So what comes in your pocket will not be what the patient is paying, it will be some part. So these are some true to life, but if you get enough numbers, it doesn't matter. That's why in one of the earlier slides I said, if you have your own hospital, actual earning is entirely yours. Because what goes to co-surgeon, what goes to hospital, bed charges, everything actually goes to the hospital, which is you. That's why having your own setup is good, but not everybody can do it. Otherwise, you should have enough numbers. Then actual earning becomes a big number. The last, who should opt for surgery, or rather, who should not opt for surgery. And I will not just speak of general surgery, it holds good for orthopedic to some extent. Like, who should take it? You should have some inclination. I went for it because I had inclination, or at least you should be neutral. You should not have a dislike for it. If you have a dislike, throughout your residency, you will be cursing yourself. Kyun liya? Why did I take it? Why did I take it? If you're neutral, it's fine. If you have an inclination, even better. You should be okay with starting off late. Most of me and my peers, most of us started making money in the late 30s, mid 30s, late 30s. If you're doing MCH, at least till you're 32, 33, you will be completing your degree. In that period, you will get married or maybe have children or maybe later. Real money will come few years after you are into full practice. It won't be from the time you start. It's not like that. You should want the heart of action. You should want to be in the thick of things. You would want to intervene and not just write a prescription or do minimal invasive procedures like angiography and all. They are not as thrilling as a proper surgery. You would want, instant outcomes. Like patient comes with some illness, I do a surgery after which he is fine. It will make me feel, yes, you will be the hero. But remember, you want to be the hero, but hero can become zero when there is a complication. There are two sides to it. So 99% of the times you will be a hero, 1% there will be a complication, maybe patient may not survive. You should be okay to take the blame. and you should be able to handle it. Okay, you should be able to handle it. Which over time you get the hang of it. There are enough rewards if you want it. So these are the kind of thought processes you should have, that you will get a monetary reward if you work. It takes time to settle, but once you settle, you can have your work-life balance, and you should want to be in the thick of things. These are my main 2-3 pointers for if you are considering taking general surgery. Everything else eventually will materialize. If you work, it will materialize. MSDNB, it's fine. It should be a good institute. You should have good seniors. Whether you want to do MCH or not is based on your appetite. If you want to practice in a metro, if it's a niche branch, you will have to do MCH. Otherwise, it gets difficult, right? So these are some of my takes on taking general surgery. Now, if there are any questions, I'll just check in the YouTube. Suddenly, I see so many comments over here. I'll try to answer as many as I can. Meanwhile, if you have any questions, you can always ask me on Telegram or on my Instagram, and I'll be happy to help. We at Conceptual Surgery, we are a platform who will guide you, handhold you through your residency days. We have a full set of, MCQ, QBank, DNB papers, live lectures, recorded lectures. The whole deal is there. You can join us. There are many senior surgeons who will guide you through your theory and practicals and entrances process. And of course, we will be accessible. So if you wish, you can join us on Conceptual Surgery app. And if you have any questions, you can ask me on Telegram or Instagram. Let me just see what comments are there. If there are any questions. So people are asking about certain specific institutes, BARC Mumbai, in terms of exposure. Yes, these are good institutes. You can definitely take them. In government jobs, is there a bias as a DNB? At least in Mumbai, there are enough government jobs. So bias is a far off thing. If someone goes for a job, they will take you. Okay, because they need people in government places. There are enough vacancies. As of now, those jobs are not permanent. But with good 1 or 2 years of work as a lecturer, maybe they'll ingrain you in the system. Okay, but at least for a few years, you will get a government job easily. Correct time to study for MRCS. MRCS is not really a must to do unless you are planning to go abroad. If you are planning to go to UK, you can give it in your second year of residency, or you can give it during your post residency phase also. It's not a very difficult exam to crack. Longer learning curve in the subject and longer settling time. A learning curve is long for all subjects, all surgical branches. There will be a long learning curve, but there is a lot of technology. So what was the thing before, where if I'm doing a lab coolie, I have to do at least 50 to 100 lab coolies to get the hang of it? Does not all good anymore, because with robotic surgery, learning curve has really reduced. So you can become as good as any senior surgeon with the technology. Like when I do bariatric surgery, we have a lot of technologies. Harmonic, you must have heard. So these kind of technologies have really made our life easy. Skill set is required more for counseling, for assessment pre-op, for post-op identification of complications. Thus, true surgical skill set is not very difficult to acquire in today's day and age with the technology. CVTS, is it dying? No, it is not dying. In fact, at least in the big cities, CVTS was run by a lot of senior surgeons, but now there is a lot of CVTS work. So definitely you can take CVTS. Okay, it is by no scope a dying branch. A lot of people, seniors in CVTS, are doing open surgeries. So open thoracotomy or CABGs or open lung surgeries. If you become a video assisted VATS thoracoscopic surgeon, there is a real demand for this. So you just need to find your own niche, right? You have to find what will work when you are in that situation. In my time, there was no robotic. Laparoscopy was new. So whenever you would see a laparoscopic surgery, you would be so fascinated. But today, everybody sees laparoscopy. Sanjana was saying in her second year end, she has been getting exposure to laparoscopy. Lot of residents today, by the time they finish 3 years, they are doing independent lap chole, lap hernias. That's a big deal. So times will change. When people say branch is toxic, branch is not toxic. The institutes can be toxic. Like if you have bad seniors, then life can be difficult. So then you have to somehow manage. That is the difficulty. You need to have a good department in the hospital that you're working in. It's not the branch. Is it preferable to do DNB rather than MCH to avoid hefty bond of 2 years? Okay. No, see, it doesn't matter, because eventually, even when you finish your DNB or MCH, you would still want some work X. If you have a bond, you serve the bond. Some work ex will always be needed. You will not jump into practice immediately. So you can use the bond as work experience. It will be fine. Okay, neurosurgery 6 years. See, any 6 year course, I am very clear on this. Many students ask me, should I opt for a 6 year, full, don't do general surgery, straight away do 6 year neurosurgery, cardiothoracic, pediatric. I feel that is taking too much of a chance. Like, honestly, it's like, marrying someone. You are giving the full commitment. After 1 or 2 years, if you realize the branch is not for you, then you are in a tricky situation. But if you do general surgery and get some exposure, then do super specialty. See, the reason we are tempted is 6 years, my life is set. It's not as simple. You may not like neurosurgery. Then you'll be like, now how to change? That option is not there. If you don't like it, you still have to do it. So rather do general surgery. Give another entrance, it's okay. Give one more entrance. It's not as competitive as NEET PG. And then take the branch that you are getting. Right? What skills should we work on in residency besides cutting? More than cutting, it is pre-op and post-op. Pre-op means how to talk to patients, how to convince them to get operated by you, especially if you're in a private institute. Because this is, you should see how your consultants convince them. Because nowadays, patients are very tricky to convince. If someone comes to me for bariatric surgery, they will first ask me for non-surgical choices. And if the person's a real candidate, like he deserves a bariatric surgery, I should be able to convince him that, boss, don't go for medical management, so popular nowadays. Don't go for other alternatives, go for surgery. That convincing you should learn little bit in your residency, little bit after also. That is the true learning. And post-op, you need to identify post-op complications. They are the true defining phenomena in a surgeon's practice. If you get a complication, which you will get, see, if you do enough surgeries, you will get complications, however good you are. Senior, most people get complications. I was working with a very senior surgeon. Sometime or the other, his patient would get complicated. It's how you identify, convince the patient that there is a complication, it will require some intervention, and he has to be with you. He should not go to some other surgeon to get it resolved. He should not, start pointing fingers at you that you are responsible. That soft skill is one of the most important skills in private practice. If you are in a government job, it doesn't matter because their patients don't really blame you because they are like, whatever you do, they are okay with it. But in private practice, it matters. Okay. So I think I have answered most of your queries. In fact, some of the names I see are quite familiar people. If you have any more questions, you can definitely ask me on Telegram or Instagram. I'll be happy to help. And if you do take up general surgery residency, please join us on conceptual surgery, where teachers like me and more senior teachers will help you through your residency and super specialty journey. Okay, guys, thank you for joining me. Take care and good night.